Good morning or good afternoon. I'm Monica Pica with Sachs Healthcare Communications, and I will be your technical producer for today's webinar. The title of today's webinar is The New Post-Acute Care COVID World, Emerging Opportunities for Respiratory Therapists. Before I introduce our moderator, Lexi Caraway, and our speaker, Dr. Seifer, I would like to give you a few housekeeping information details. Today's webinar is being recorded. You may ask your question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab, also located on the right side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. And please make sure you are not behind a firewall, as this will prevent you from viewing the presentation. Our moderator is Lexi Caraway. Lexi Caraway is currently a senior patient trainer for Hillrom and the former manager of respiratory at Sarah Bush Lincoln Health Center in Mattoon, Illinois. Her department participated in the survey mentioned in the recent study, Prevalence of Burnout Among Respiratory Therapists amidst the COVID-19 pandemic. Lexi has published several abstracts at AARC Congress, including a study on thermographic imaging to detect and prevent pressure injuries. She has presented at several local and state respiratory care conferences. Welcome.
Good morning. Thank you, Monica, for that very kind introduction. Before I begin, on behalf of Philips and Sachs Healthcare Communications, I want to thank all the respiratory therapists in the audience for your hard work always, but especially during the pandemic. Happy Respiratory Care Week. The title of today's webinar is The New Post-Acute Care COVID World, Emerging Opportunities for Respiratory Therapists. We are excited to have a very innovative speaker, Dr. Seifer. Dr. Seifer has served as both Medical Director of Population Health at St. Louis Health System in Potsdam, New York, as well as Chief Physician Executive for Innovation and Transformation, Adirondack Health Institute in Glens Falls, New York. Dr. Seifer's research interests and experience include smoking cessation, pulmonary rehabilitation, idiopathic pulmonary fibrosis, COPD, and non-cystic fibrosis. As a recognized thought leader in pulmonary healthcare, Dr. Seifer has served as a member of multiple advisory committees, both at the state, federal, and within the private sector. The speaker has disclosed no relevant financial relationships. This educational activity is approved for 1 contact hour for nurses and respiratory therapists. A link to obtain credit will be available at the end of the webinar. Support for this educational activity has been provided by Philips. And now I will turn the presentation over to Dr. Seifer.
Good afternoon, everyone. I was just told as we were preparing to come on live that there are 1,500 plus people attending this presentation. So I am honored that you have all taken the time to be part of this today. So before I jump into the content of my presentation, I just want to tell you a little bit about myself that's relevant. I completed my pulmonary fellowship at Duke in 1989, so that certainly dates me. And I've been in this space now for over 30 years. And during that time, I have seen a tremendous movement, evolution in this space. Certainly during my entire tenure as a pulmonologist, I've had a very close relationship with respiratory therapists. And back in the day when I was working primarily in the acute care setting, in the hospital, in the ICU, when things went south, the first person I wanted there with me was a respiratory therapist. So I just want you to know that you all have a lot of value to me as a pulmonologist. Now, what has happened, COVID certainly was a scourge on the world, but I'm the kind of person who always looks to turn lemons into lemonade. And COVID did create opportunities that would not otherwise have existed. And one of the things that has happened because of COVID, healthcare was moving at a snail's pace, starting to adopt, early adopters like myself, concepts of telemedicine, is interacting with patients without physically being together, and remote patient monitoring. But it was moving at a snail's pace. And then COVID hits, and suddenly we can't see patients. Everything shuts down. And the only way that we can reach out to our patients is through the telephone, either a voice or a video call. So my practice went from 100% inpatient, in personal, in the office, old school, to 100% phone calls. And so there was, and one of the things that helped that was the payers said, look, we have to reimburse the health systems for this kind of delivery. So suddenly there was parity for these calls. I'm a mission driven person. I realized years ago that medicine is a margin driven business. And you're not going to be innovative and be able to move things forward in an innovative way unless you also pay attention to margin. So the key part of advancing telemedicine was the parity. That is, you could be reimbursed for this. Right now, as COVID restrictions are starting to fade away, people are asking me, are we going to go back to the old model of 100% in the office contacts? And the answer is no. And my prediction, I have a crystal ball here. My prediction, at least for pulmonary, for my practice, is that it's going to settle in about 50-50. That about half my work day here in the office, I'm here in my office right now, will be these virtual calls, and about half will be in person, maybe even less, maybe 25% in person. The beautiful thing about COVID, what we've learned is that a lot of what we do as pulmonologists can be done virtually. And providers have realized that they can take good care of their patients and not necessarily have to lay their hands on that patient every visit. And patients have come to adopt this and realize that they're getting good care as well. And in fact, this just came out. It's so new that I didn't have a chance to make a PowerPoint graphic, but this just came out this month. I just got my hands on it a couple days ago. It's New England Journal of Medicine Catalyst report. And the University of Rochester Medical Center, URMC, which is, I'm in New York, they looked at their experience with telemedicine, and basically what they came up with was quality care is not compromised, patients like it, and the providers like it. So that's kind of our jump in here. Let's see if this works. I'm gonna try to move on to the next graphic. Okay, so I hit it. I got to go back now. IT is not my strong suit. So learning objectives. You can all read as well as I can. We're going to talk about opportunities for RTs in the present and in the future in this new world order, and basically talk about skill sets that I believe that RTs need to master to be leaders in the post-acute care post-COVID world. All right, so our population is aging. People like myself, baby boomers, we're not dying. We're never going to die. We are immortal. So we keep living on, and our population is aging. The problem is our health system was not designed to deal with an aging population with multiple chronic conditions. Today, 2022, about half the population has at least one chronic condition. 85% of individuals 65 and older. I am in that demographic. I just turned 66 this month. I have an 85% chance that I'm gonna have one or more chronic conditions. Luckily, right now I have 0 chronic conditions, but I am an exception to the norm, I guess. And then 60% of people have 2 or more chronic conditions, of which respiratory COPD or some respiratory condition is likely to be one of those two. So our current health system, the way it was designed in the 60s, was not designed to manage this health system. And respiratory therapists were not trained and are still not being trained to deal with this emerging, aging population. I did hit it. Again. There we go. So what I would like to do with the time that we have today is to tell you what I think are the current and future opportunities for RT. And this is just so you all realize you're not alone in this boat. 2/3 of physicians will admit that we're not prepared to deal with this aging population as well, not with the illness, the psychological aspects, or the social aspects of chronic care. So our health system, not just RTs, our entire health system is really not prepared to deal with the present reality. And certainly up until 15 years ago, even 10 years ago, the patients would get sick, come to the emergency room, get hospitalized, get better, go home. We would cobble together some home services, it was a Hail Mary pass, and hope that the patient stayed out of the hospital. And the bottom line is, up until very recently, we were doing a very poor job with this. If you look at COPD, for example, at our institution here in upstate New York, I'm here for a reason. This is a very rural location, and not just rural, but resource limited. So I live in a very rural, resource limited part of the country. And the reason why I chose to practice here for the past 7-8 years is because if I can design a population health program for pulmonary patients in Chicago or New York or Atlanta, that doesn't necessarily mean that that's going to be scalable and to rural communities. But if you can make something happen here, make it work here, then you have something that's truly portable and scalable. So I choose to live here in a resource limited rural community. I'm also an avid outdoorsman, and I love everything that this region provides me recreationally. So um, I'm very happy being here because it fits my needs professionally and personally. Back in 2003, I was asked to participate in this day uh, in Washington, D.C. at the Longworth House of Representatives building, and it was titled Managing Chronic Illness in Public Programs. This is almost 20 years ago. And it was a who's who of people that were there. The Robert Wood Johnson Foundation was there. The Central Budgeting Office was represented. CMS was represented. The Agency for Healthcare Research and Quality was represented. And I was there. I kind of snuck in the side door. At the time, I was the co-chair for the Respiratory Steering Committee for TennCare, which was Tennessee's restructuring of Medicaid. The first speaker was the gentleman from the Robert Wood Johnson Foundation. And his entire thing, his presentation was based on this. Chronic problems, shared solutions. Chronic problems, shared solutions. And he kept saying that over and over again. And he was lumping COPD in there with diabetes and hypertension and the big 5 chronic diseases. And as I'm listening to him, I'm thinking, that doesn't work. That's not true. COPD is a unique problem that requires unique skill sets and unique solutions. And that's where you come in, the respiratory therapist. You are highly trained professionals to deal with this patient population. So when the Robert Wood Johnson Foundation guy finished and he left, I followed him. And I get up there and I said, that was a very nice presentation, but common problems, shared solutions doesn't work when it comes to COPD. And I said it requires unique skill sets and unique solutions. And I illustrated my point. My follow-up was, I said to the audience, there's about 150 people crammed into a room that would have comfortably sat 50. And I said, how do you diagnose hypertension? What is hypertension? How do you diagnose it? These are lay people. Everybody, you grabbed anybody off the street, they would say, you put that thing on your arm, the blood pressure cuff, there you go. How about diabetes? What is diabetes? My patients in Tennessee would say, my sugar's up. So they'd have a high sugar. And how do you diagnose diabetes? You check the blood sugar. Then I asked the question, what is COPD and how you diagnose it? And I got blank stares from the entire audience. So COPD is a very unique problem. The general public does not really know what it is, and they certainly don't know how it's diagnosed. And even today in 2022, over 40% of PCPs still think they can diagnose COPD by laying of the hands. That is history, physical examination, and they diagnose COPD. And I know the respiratory therapists that are listening to me are smiling and nodding their heads. There's only one way to diagnose COPD. COPD is defined by pulmonary physiology, by pulmonary function, spirometry. What percentage of PCPs have spirometers in their offices? Less than 50%. When I first came here, the PCP is not one PCP had a spirometry device in their office. Now every PCP in my health system has spirometry in their office, and they know how to use it because I taught them how to use it. So things are getting better. It's a slow movement, and respiratory therapists, again, are critical to this evolution. So in New York State, there are 13 respiratory therapy programs, 9 associate and 4 baccalaureate. And I know for those people that are listening that 99% of what you're taught during your training is focused on acute care, because the registry exam, 99% of the questions are focused on acute care. And these programs that you're graduating from certainly want to look good. And the way they look good is that they can say, 95% of our graduating class passes their registry exam. So they're going to prepare you to pass that registry exam. But the bottom line is the present and future need for respiratory therapists to really make a difference with this patient population is in the post-acute care setting. And you all are not being trained to function in this post-acute care setting. Good luck trying to read this. It's very, it's very small. But let me tell you what this represented. I'm not sure how many of you are actually in the state of New York attending to this webinar, but the New York State, our governor, who's no longer governor, years ago convinced CMS to give him $8 billion, that's with a B, dollars, to come up with a new solution for managing patients in the state of New York. And New York was divided into 25 geographies, and each geography got a certain amount of money based on the number of lives that geography was covering. The Adirondack Health Institute received $187 million. Make a long story shorter, I got $750,000 from that and developed this soup to nuts management program for COPD, for our health system. And the very first 2 columns to the left, that's all pre-hospitalization. And then the patients get hospitalized, module 3, the top, and what happens to them during the hospital stay and then the post-acute care stay. That's where the money's at. For those respiratory therapists who are staying up with the literature, you know that there's a significant number of patients with COPD that have a comorbid disease. It's called bronchiectasis. And from work that I did and published in 2017, the number of patients in the United States with comorbid bronchiectasis is about 4 million. And other colleagues of mine, what it's shaping out to be that about half of patients with moderate, severe, and very severe COPD have comorbid bronchiectasis. And if you don't identify those patients with that comorbid process, these are the patients that keep coming back to the emergency room, keep getting readmitted. The key, the secret sauce to the success of this program was a respiratory navigator. If I was a respiratory therapist finishing my training right now, that's the job I'd want to have. I'd want to be a respiratory navigator. And I can tell you that what the respiratory navigator did was she would every morning go into the hospital and see every single patient that got admitted to the hospital with a respiratory diagnosis, certainly with COPD. And the first thing she did when she went into the patient's room was to see if the patient actually had at least a PFT or a spirometry to actually confirm the patient actually had COPD. What you may or may not know is that about 30% of every single patient right now in 2022, October 26, about a third of the patients admitted to acute care hospitals with a diagnosis of COPD who remain in the hospital for a number of days being treated for COPD, in fact, do not have COPD. That's pretty embarrassing. Well, that doesn't happen at our hospital anymore. If you get admitted to our hospital with a diagnosis of COPD, and we can't find in the medical record that you've had documentation that you have COPD, we do a spirometry in the hospital. And if you don't have COPD, well, you fall out of the bucket. Then the respiratory navigator would then ask certain questions. Hopefully you're familiar with the CAT score and other questions that support that. And if the patient gives a story of frequent exacerbations of their COPD characterized by cough and sputum production, we do a high-res CT scan. And if we document bronchiectasis, they start getting treated with HFCWO, high frequency chest oscillation, while they're in the hospital. And then when they get discharged from the hospital, they don't leave the hospital unless they have an HFCWO device arranged for them upon discharge. Now, once they go home, then when this program was being financially supported by the district money, our hospital sent out an RFP, and it turned out there was an organization called Encore that we thought were the leaders in the post-acute care space. So our hospital collaborated with this organization called Encore, and the patients continued to receive support by the RT in the outpatient setting. That support would include in-home visits if necessary, but also televisits, and we're going to get into that in more detail as we move forward. Hope everybody is still with me. If this was a live conference, I'd be looking at you and assessing whether I had zigged or zagged too many times and lost you or not, but I hope you're still with me. So what is Encore? Encore is this organization that represents multiple colleagues of mine. I'm actually part of it. I helped design this. But back in the day, when I finished my fellowship and started practicing, there was nothing once the patient got discharged from the hospital, they just kind of went out into the ether. And it was clear to me that we needed something for this post-acute care patient population. So when I was in Chattanooga, Tennessee, back a long time ago, I developed this program. Meanwhile, other colleagues of mine across the United States, one colleague was developing his program. It was called CHROME at the time, Chronic Respiratory Outcomes Management. Another colleague of mine in Pennsylvania, he had this program called DASH. I can't remember what those 4 letters stood for, but we were all in the same space trying to come up with solutions. Eventually, it's a long story. Eventually, we came together and we formed this organization called Encore together. And Encore has developed over the past 7-8 years proprietary software called Nexus, which it is now using with DMEs throughout the United States to help these DMEs provide more than just widgets, more than oxygen, more than HFCWO, actually provide comprehensive population health management for this population. And again, the key driver here is the respiratory therapist. Again, you can see that you all are the secret sauce to the success of this program. And I have to tell you, getting back to the graphic where I showed you the program that we rolled out at our hospital, which, by the way, reduced hospitalizations for COPD patients by 35%. So it was very effective. The RT again was the secret sauce to the success of that program. So again, now let's go back to what's lacking. Your respiratory therapy training during your formal education is focused on the acute care setting. And you all know what you have to do in acute care setting. The post-acute care setting, it's very different. You're there with that patient, and it's your job to engage that patient effectively and to help them self-manage. So you really need skills in effective engagement, which you're not taught. And now I'm sure some of you that are listening have various backgrounds before you became respiratory therapists. I actually was a psych major. I got my Bachelor of Science in psychology, and I worked as a mental health worker while I was in medical school during the summers. So I'm a bit of an oddball, being a pulmonary critical care specialist with a background in psych. And I'm sure some of you respiratory therapists have had some kind of training like that, maybe social work or psychology, but it's not part of your formal education. And a, a really important part that's missing in your education is how to engage a patient effectively. So we're going to get as much time as allowed. I'm going to help you, going to give you at least a dip in the pond on some skill sets that would help you be more effective in this post-acute care setting. So again, the focus in the post-acute care setting is not the widget. It's not the oxygen machine. It's not the tank. It's not the HFCWO. It is the patient. And that's a whole different way of looking at things. It's focusing on the patient and helping that patient, finding out what's important to that patient, what motivates that patient, and not making assumptions, but listening to the patient and then helping that patient move from point A to point B. I don't know, maybe some of you have had motivational interviewing training, and that's all about helping the patient move from point A to point B. But the key element of that is finding out what is important to that patient, not as what's important to you, but what's important to that patient. So it's all about driving that patient to reach their goals. And this is another way graphically of looking at it. Also, it's your job as the respiratory therapist working in the post-acute care setting to make assessments of the patient. Are they using their medications correctly? And it's unbelievable to me, but from some of the work that I've done with my colleagues at Encore, we've discovered that 60% of patients with moderate, severe, and very severe COPD are not gold compliant. So we see patients with advanced COPD who are not on a LABA, a long-acting, a LABA, and the thing that's missing most of the time is the LAMAs. So, as you all know, as respiratory therapists, if you have moderate, severe, very severe COPD, a LAMA is a foundational intervention, and we find all the time patients being managed without LAMAs. So, going into the home, working with the patient, discovering these gaps in care is fundamental to helping turn these patients around. Also, their oxygen. What is the what is the most common oxygen prescription for a patient upon discharge from the hospital? I can hear you all saying 2 liters nasal cannula continuous flow. Yes, that's like sending everyone home from the hospital with diabetes with the same insulin prescription, or somebody with diabetes, hypertension with the same antihypertensives. It doesn't make any sense. Every single patient that I see in my practice, I check their oxygen while they're sleeping, when they're sitting, and when they're ambulatory. And some of my patients actually have 3 different oxygen prescriptions. But what percentage of patients out there with COPD actually have had their oxygen checked when they're sitting, when they're walking, when they're sleeping? It's a minority of patients. So one of the things that a respiratory therapist will do in the post-acute care setting is actually help establish what the oxygen requirements for that patient really are. And then also assessing the patients for these comorbidities, such as non-cystic fibrosis bronchiectasis. And if you identify a patient who is giving you a history of frequent exacerbations of their COPD, characterized by cough and sputum production, requiring multiple courses of antibiotics over a period of 12 months, that patient has a neon sign over their head going, I've got bronchiectasis. I at least had the bronchiectasis phenotype, and I should have access to effective airway clearance. Oh, let me see if I can go back. I did. All right. And then now there are emerging technologies just in the last couple of years, true portable non-invasive ventilators or true portable assisted ventilation devices. So right now there's this thing called the L2K. It's made by Hillrom. It's about this big, it weighs a pound, and it's truly portable. And then there's another device that's right now it's owned by a company called Inogen. It's called TAV, T-A-V, tidal assisted ventilation. Probably most of you have no experience with it, but again, it actually does some work of breathing for the patient. This is the next horizon line really within the pulmonary space. You know, I've been, as I said, been in this space since 1989, and when I started off as a pulmonologist, I could count on less than one hand the number of medications we had to treat patients with COPD. We didn't have, you know, CPAP, BiPAP. We didn't have. I'll tell you when ipratropium bromide hit the market, that was huge. I mean, that was the first muscarinic antagonist that did not cross the blood-brain barrier. So I have seen these advances, incremental advances in the medication, and then a huge breakthrough was the advent of nebulized LABAs and then nebulized LAMAs. And today now, my advanced patients with, my severe patients with COPD, I can give them everything they need, their long-acting, their LABA, their LAMA, their ICS, all nebulized. And then this emerging big leap in care is the biologics. And there's multiple biologics out there that have allowed me to up my game with management of COPD patients. But then, okay, so right now, before the emergence of these truly portable non-invasive ventilators, that was as good as it got for this patient population. That my patients, they quit smoking, identify the comorbidity of bronchiectasis, I have them gold compliant, I have them in pulmonary rehab, I've crossed every box. But still, there's a core group of patients that just can't do the work of breathing. They go walking, they get 200 feet, 300 feet, 400 feet, and they just vapor lock. They can't go any further. Their visual analog score, the Borg score shoots up, they redline on the Borg score, and they can't walk. But interesting, if you put the oximeter on their finger, many of those patients, their sats are still in the 90s. So increasing their oxygen isn't going to help them. But that is the knee-jerk response that a lot of providers do. They just jack up the oxygen, but it doesn't help. And if you had a capometer and could measure their CO2s, CO2s don't suddenly climb and they hit the wall. It's that they can't do the work of breathing. And I've done some preliminary work with these devices that are just emerging right now and having robust responses where a patient who could only walk 200 feet and their respiratory rate would shoot up into the high 20s, even high 30s, and their Borg scales would redline. I let them rest and I put them on one of these truly portable non-invasive ventilators and then go 600 feet, respiratory rate stays in the 20s, Borgs don't get above 4 or 5. That's exciting new stuff that is coming out. And obviously, there's opportunities there for respiratory therapists to be working with those patients in the outpatient setting. What is this graphic? So when a patient gets discharged from the hospital, initially it's high touch, high tech maybe, but as time goes by, what we try to do is get the high touch element. We try to minimize that and replace it more with high tech because there's only so many respiratory therapists out there who have training in the post-acute care setting. And that's why I'm doing this presentation today, because I want to basically wake you all up to this opportunity, this need, and this opportunity. So But right now, respiratory therapists, to find a respiratory therapist who is well trained and has experience in the post-acute care setting, it's very difficult. And as you can see, one of the things we do is we do these IVR calls. They're very simple. They last about a minute, just a few questions, and but they're very helpful in assessing what's going on with the patient. We also now have remote patient monitoring devices, which I am working with companies in that space as well. We'll get to a graphic further on out that'll support that. Okay, so Nexus, for example, this one company I mentioned, Encore, which uses Nexus, which I helped design this. This is what the respiratory therapist has in their hand. It's an iPod, not an iPod. What's it called? An iPad. It's called an iPad, and it's very user friendly. And if I can use it and it doesn't make me anxious, then it's good, because this technology tends to make me anxious. So it's very user friendly, color coordinated, very easy for the respiratory therapist to use on the go, keep it in their car, walk into the patient's home with it. And everything is there. The dashboard, everything is there. It's I think it's brilliant the way it's designed. These for the patients, these goals, so patients will set their own activity badge, their own breathing badge, their own medication badge. So they set their goals, and it's your job as the respiratory therapist, as the respiratory navigator, working in this new post-acute care, post-COVID world, to be that partner, to be that colleague with the patient. And I'm going to get to that in more detail, hopefully, if we have time. An hour is 50 minutes is not enough time to cover this topic completely. So this is what the dashboard looks like. And what's happening right now, healthcare is moving from this fee-for-service to this pay-for-performance world. And I am part of that transition, certainly in the respiratory space, and Encore is certainly part of that. And I am working with pretty much everyone in this space. If anybody's read the book, The Tipping Point, I am a connector. I grew up there, people, this thing about thinking inside the box and thinking outside the box. Even as a kid, I never even saw the box. So, I see connections that other people don't see, and I'm in this space. And what's happening right now, remember, no margin, no mission. We're figuring out ways to get payers to actually to finance this movement where the respiratory therapists can actually get paid, that we can actually bill for these respiratory therapists that are doing these services. Up until now, the respiratory therapists that were doing these services in the home setting, there was no way to bill for that. So whatever company that was engaging the respiratory therapist, they were paying out of pocket. They were minimizing their profit margin to bring in the respiratory therapist to do this. But why were they doing it, and why are they doing it now? Because that's giving these companies, these DME companies, a market share advantage, because they can provide services, improved outcomes, and provide services to the PCPs, where the PCPs go, I'm going to stay with that DME because they're not only providing widgets for me, they're giving me useful information about my patients that allow me to better manage my patients and take better care of them. And now they're not calling my office and bothering my nurses and calling me and bothering me. So they see value in this, and that's what's happening. But hopefully within the next couple of years, the payers themselves will start seeing the value in this and paying companies when they bill for the respiratory therapist, actually reimbursing for that service. So this is something that's in flux. This graphic is for me to show you, I don't know if I have a pointer, if you can see my pointer, but these are these wearable devices. And the third one from the top is the Spire device. That's the one I have experience with, and I have over 50 patients that have Spire technology. And you glue it into their underwear, and then you could throw the underwear and wash it, put it in the dryer. They just wear it. So there's no work to it. It's 100% passive for the patient. And they have a little thing that's the size of a phone in their house. So if they're out and about and it's collecting data, when they get home, the underwear talks to the cell phone thing, and then that goes up into the cloud, and then there are respiratory therapists that are monitoring that data. And I've established bumpers for those patients, so they go outside of those bumpers that I've established in regarding certain parameters. Then that gets escalated to me, and I can then intervene with my patients. I have found this. I wasn't sure this was going to add value to my practice because my patients are very well managed, as you can probably tell. But it does add value, even though most of my patients have my cell phone number. When they get sick, they don't want to bother me, so they don't call me, and then they winding up in urgent care in the emergency room. So it's no question that remote patient monitoring is going to be part of the future. And I just did yesterday. I was on a webinar. It was called. I was on a panel. The two other people on the panel was the chief scientist for R&D for respiratory health at Baxter, which is a global multi-billion-dollar company, and then the president and CEO of the COPD Foundation was the other person, and then myself. There were three of us, and it was called Healthcare 2040: The Future of Chronic Pulmonary Care. So we were all supposed to be like futurists, predicting what the future of pulmonary healthcare was going to look like. And I made this statement that I believe in 20 years, remote patient monitoring, like with devices like this, and telemedicine will be a foundational way that we manage these patients. And you can see creates huge opportunity for emerging respiratory therapists. Okay, so I'm not going to do the rest of this justice. I got 10 minutes to cover this, but the biggest problem in communication is the illusion that it has taken place. Most providers talk at patients. They don't have true engagement. And in 10 minutes, I'm going to take you through a talk that I actually will do whole day workshops for organizations to teach them about dynamic dialogues. So I developed this, it's trademarked, it's called Dynamic Dialogues. It's a tool for empowering transformation in healthcare. And it's a methodology for facilitating true engagement. And typically the way that we are taught is that someone comes up to us and bangs us over the head with a bunch of didactic knowledge. That is, they connect with us from the neck up. They just data dump on us. But yes, you can memorize something and barf it back, regurgitate it back for a test, but is it actually going to change your practice behavior? No, it won't. So how do you change practice behavior? Well, typically the healthcare provider, physician, the respiratory therapist, the nurse, we go in a room and go, here I am, and now you're going to listen to me. And I'm going to ask you a lot of closed questions, and you're going to answer those questions. That is not how you engage a patient effectively. So I take the there you are approach, and it's very hard to do this on a webinar, but I was actually doing a health coach course last night, 2 hours with undergraduates at a local private university here at Clarkson University. And this is what I was talking about. So I go into a room with a patient. First thing, it's all there you are. I'm focused on that patient. I'm all about that patient. And then what I'm trying to get to is to here, this point. Here we are. This is a relationship I'm trying to build. I'm trying to get to a place called of mutual accountability, which I'm going to explain. This is how I define mutual accountability. And I wish if you've got a cell phone right now, pick it up and take a snapshot with your cell phone, because this is worth reading and studying. Mutual accountability is the foundational principle by which the patient and the healthcare team, which you are a vital part of, grounded in reciprocal respect, open communication, and trust, agree to be held mutually responsible for commitments that they have made to each other. Take a snapshot of this, please. This then allows an alignment of expectations and the development of a clearly defined action plan with credible and attainable goals. Mutual accountability empowers patients to take a proactive role in their healthcare management and become principal stakeholders in the outcomes of their healthcare choices. A snapshot of that as well. Every relationship that I have with a patient, every relationship that I have with a colleague, ideally, I try to have this kind of relationship with my friends, with my children, with my significant other. This is how I live my life. This is something that is teachable. I do teach it, and it's something I believe that should be taught to respiratory therapists during your formal training. Because if you can master dynamic dialogue and you can get to a place of mutual accountability with your patients, then you can do true you can have a truly transformative relationship with your patient. You can engage them effectively. I can't talk about this and not get goosebumps. I mean, the fire is in the belly. You know, I have a tobacco cessation program that no one can touch. We're talking an 85% quit rate at 6 months, chemically validated. Nobody can get near that. And people go, what is the secret sauce, Dr. Seaver? Do you have a magic wand? No. The secret sauce is dynamic dialogue leading to mutual accountability, leading to true transformation. So if you can be transformative in your interactions with patients with COPD. Let's quickly go through in 4 minutes. I know I have to stop talking in 4 minutes. One of the key elements to making this work is you have to be present. And what does that mean? That means more than just turning off your cell phone. It means clearing your mind, leaving your personal baggage at the door, being in the moment. And I can tell you, when I meet somebody who's truly present, that is very bonding. That is very attractive. I find another human being who's very present. I find that a real attractive trait because it's hard to find today. And you should all be working on how can I be more present in the moment, not thinking about the future, not thinking about the past, in the moment with the patient. The other thing that's very important is asking open-ended questions. I do this. I'll get up in front of a congress of 150 people and I'll ask a bunch of people, what did you have for breakfast? What did you have for breakfast? And I get a shopping list back. But then I'll ask somebody, I'll say, how was your breakfast? Which is an open-ended question. And suddenly the person becomes effusive and says, I had a great breakfast. I read the New York Times. I used my blah, 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 and I made a poached egg. But providers typically don't ask open-ended questions because they want to remain in control. So they go in a room and they machine gun the patient. You as respiratory therapists, nurses, doctors, we all do it with questions. Boom, 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 boom. That is not going to build that's not a dynamic dialogue, and you're not going to build the kind of relationship you want to build with the patients to be successful as a respiratory therapist in the post-acute care setting with these patients. And there's something called positive intent. I'm sure you all encounter patients that are aggressive and agitated and angry, and they're not nice. But especially in the post-acute care setting, if they let you in their house and you're in that room with them, or I walk into a patient room, they're there and they're not wearing orange and they're not in shackles, they want to be there. They want to be helped. And they may make it difficult for you. They may be agitated and not happy people. But if you focus on the positive intent, the fact they're there and they want help, eventually you'll be able to navigate around what the issues are and be able to do your job and do it well. You got to show respect. Before I go into every patient room, I knock on the door. And then I walk in and I introduce myself. Even today, I see more and more providers knocking on the door, but I see a lot of doctors, a lot of providers, nurses, respiratory therapists just walking in a patient's room without introducing themselves. You're not showing respect, and that's not going to help you. Also, again, I'm pushing through this quickly. I've done whole day workshops on this, but you got to be authentic. And I was talking to these students yesterday. One of them was a Doogie Howser. She was a senior in college. She was 17. I don't know. She must have started college when she was 14. But there was no one in that group that was older than 23. And I said to them, and this is an age where you're trying to figure out who you are and you got to be authentic. So whoever you are, figure out who you are and be authentic. Authenticity is a very powerful tool when you're trying to effectively engage another human being. Don't try to be somebody you're not. But you got to figure out who you are first. Affirmation, positive affirmation. Everybody wants to tell somebody when they're not happy. When you go to a restaurant, things don't go well. And I do speak up when I get something that's going right in a restaurant. I'll say something to the server, not in a mean way, but I'll speak up. But at the same time, when I get great service, I will call the manager over and say, I want you to know that server just did a great job. She deserves kudos. Anytime I have an opportunity to give positive affirmation, I will do it. Empathy. So where does all this come from? I'm going to finish off on empathy because I ran out of time, but I'm going to finish off with empathy. Where does all my passion come from? My passion comes from empathy. I care. I like people and I care about people. And I hope that everyone who's listening, if you're a respiratory therapist, I hope you have empathy and I hope you really care about people. And you, as a respiratory therapist, are the secret sauce to the future of this space. And I'll turn this back over to the moderator.
Thank you, Dr. Seifer, for that very informative presentation. Now I will tell everyone how we can obtain our CEUs for this session. This educational activity is approved for 1 contact hour. To obtain CE credits, go to www.saxtesting.com/BO. You will need to register at this site. Complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. Support for this educational activity has been provided by Philips. An archive on-demand version will be available on betteroutcomes.org. An email will be sent to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. And now we have time for a few questions. Dr. Seifer.
Can I say something before we entertain the questions? Just so you know, right now, I'm going to give you the name of 2 national DMEs that are looking for respiratory therapists who want to work in this new world where the respiratory therapist is vital to the management of these patients' acute care setting. I have no financial relationship with either one of these DMEs. One is Adapt Care, and one is called Quipt, Q-U-I-P-T. So those are 2 companies that are national that are looking for respiratory therapists to function in the capacity that I'm discussing. And with time, what I'm predicting is that this is going to become standard of care with all DMEs throughout the United States.
Thank you for that. I have a question here from Daniel. Do you have any advice on how to approach a pulmonary group to use a respiratory therapist as a navigator in the home?
Yeah. I mean, what I would do personally if I was a respiratory therapist and there was a pulmonary group near me, I would contact them and say, look, I'm a respiratory therapist. I have this many years of training, da 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 da. And I would be very interested in working with you all as a respiratory navigator. And they'll probably look at you and go sideways and go, well, what is a respiratory navigator? So you have to have it all written out so that you can say, I attended this webinar. There's this organization. You're going to have to sell yourself. But if you come in with your T's crossed and your I's dotted and your ducks in a row, and you make a case for it, you'll get their attention. You will find somebody. I mean, that's what's happening. In Tennessee, for example, there's the predominant group of pulmonologists. There's like dozens of them. They have now employed respiratory therapists to be their respiratory navigators because myself and my colleagues approached them and proved to them that there was an economic model for them. Remember, the margin to support the mission. So that's my best answer for you at this point. You're going to have to be a self-starter, self-promoter, and have your ducks in a row. And I'm going to give you all my cell phone number and email at the end of this webinar. I'm happy to be a resource to you, whoever this person is. And if you are able to set up a call between me and this respiratory group, I'd be happy to advocate for you.
Perfect. Thank you. I have a 2-part question here from Amy. First of all, are PFTs reimbursed when completed prior to discharge? And secondly, when a bedside PFT or a PFT is completed in the hospital, do you recommend a PFT being done at a later date to determine if the patient is at baseline or not.
Okay, this may be a controversial answer. I don't do PFTs while the patient is in the hospital. The patient's acutely ill for some reason. I want to know what their lung function is when they're at their baseline. So that's not the time to do the PFT. Now, you could say, well, Dr. Seifer, you said you were doing bedside spirometry on these patients. And I got some pushback from some providers when I first started this initiative, and they said, we don't want spirometries on these patients. Of course, they're going to be horrible. I said, all right, I'm not trying to quantitate whether they have mild, moderate, severe, or very severe COPD. The purpose of the spirometry is, do they have airway obstruction? So if you have somebody who was admitted to the hospital for an acute exacerbation of COPD and their airway mechanics are normal, it's not COPD, guys. So you use the do they have airway obstruction or not? I'm not trying to quantitate it. So I save the PFT for discharge. You asked the question is the spirometry reimbursable while it's done in the hospital? Honest to God, I don't know. I assume so, but maybe it isn't. Maybe it's just bundled into the whole thing. I don't know. That's not my wheelhouse. I don't know. But at our hospital, we do bedside spirometries if we can't document there's a PFT in the chart that documents airway obstruction.
Okay.
Or a spirometry in the chart that documents airway obstruction.
Quick question here. Does a patient need to be diagnosed or have documented history of bronchiectasis to be approved for high frequency chest oscillation?
Okay. I'm glad someone brought that up, and I wish we had more time. I've got just a few minutes here. Okay, so I fought the battle with others, with CMS, to get them to pay for HFCWO on a COPD patient that we did a high-res CT scan and showed anatomical bronchiectasis. That's where we are now. However, because of COVID, the COVID waiver, we were able to get patients on HFCWO without the high-res CT scan. And in New York State, we were always able to do that for our Medicaid population. So this data has been, I presented this data at CHEST last year. Guess what? The anatomy is not what's important. It's the phenotype. So what we've determined, and a manuscript I'm working on right now, is we have a group of patients right now, 400 patients that have COPD that have the bronchiectasis phenotype. What I mean by that is they clinically are presenting with cough, frequent exacerbations characterized by cough, sputum production, necessitating multiple courses of antibiotics over a period of a year. And we did the high-res CT scan. It did not show the actual bronchiectasis. These CT scans did not demonstrate anatomical bronchiectasis. However, they got treated with HFCWO. And we compared that cohort of patients to patients that had anatomical bronchiectasis, and there's no difference. So it's going to be very hard for CMS to now say, never mind, you got to go back to doing that high-res CT scans to prove the anatomical bronchiectasis, because we now have the data because of COVID and the COVID waiver that it's what's important isn't the anatomy, it's the phenotype, it's the clinical presentation. So what I'm telling you right now, COVID waiver, you don't need the high-res CT scan. If CMS tries to pull the rug out from on that, they're going to hear from me and a lot of other people like me saying you can't do that because you told us years ago, you show us the data and we'll support this. We now have the data and it's being published as we speak.
Thank you. Thank you very much. So we have ran out of time for questions. We had lots of great comments. I would just like to say thank you again to Dr. Seifer for today's presentation and turn the presentation over to Monica.
Thank you. And immediately upon the conclusion of this webinar, you will be presented with an online survey. So please keep your web browser open. We appreciate your feedback. And to obtain your CE credits, please visit www.saxtesting, that's SAXE, testing.com/BO. Please register at the site and please complete the evaluation. Thank you again, and on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips, I hope you enjoy the rest of your day.